So, in terms of the clinical disease states for prostate cancer, we have the hormone-sensitive subtypes, which include the newly diagnosed localized disease, the non-metastatic biochemical relapse, and metastatic hormone-naive patients. And ultimately, these patients will move into the castration-resistant group, which can either be non-metastatic or can be metastatic but asymptomatic, or metastatic symptomatic, and whether they have received chemotherapy or not, we can subclassify them as chemotherapy naive or post chemotherapy. It's important for all of us to know that prostate cancer is not a single team disease. We need the whole GU oncology team on board, which includes the urologist, the medical oncologist, the radiation oncologist, pain specialist, and all these other specialists that will be involved in the care of a patient with prostate cancer. So previously we used to look at all the patients in a similar way, but now we know that if we put them in different categories, that their outcomes will be different. And if you look at localized disease, the importance of classifying patients in different risk groups gives an element of prognosis and also determines the type and the extent of treatment. Recently, it's become very important to risk stratify patients in the metastatic setting, especially those who are hormone sensitive, because we know that some patients will have an indolent cause of disease with long survival on androgen deprivation therapy alone, but we have patients who have more aggressive forms with short responses to ADT alone, and these patients will require different treatment. And it can actually be predictive of treatment response. And just to highlight the risk stratification for localized disease, it depends on really which group you want to follow. There are more simplified European classifications, such as the one for EAU, but the NCCN has a very extensive categorization from the very low risk to the very high risk, and mostly looking at the clinical stage, the Gleason score or grade, and the PSA level to help you in risk stratifying these patients. And when you look at the patients on the metastatic range, over the last 10 years, because of the Chartered trial and the Latitude trial, there are different criteria. So not all patients with hormone-sensitive metastatic prostate cancer are looked at the same. Patients have a worse prognosis if they have visceral metastasis and or have more than 4 bone lesions, with one of those lesions beyond the vertebral body. And in the Latitude criteria, they add the Gleason score in the risk stratification for these patients. And this actually has an impact on the type of treatment the patient will receive and the kind of response, and also the mortality from the different groups. So just looking at what is the evidence for the current systemic therapies in prostate cancer, I think the biggest advance that we had was way back in 1941, after this publication by Huggins and Hodges, which actually established the link between androgens and prostate cancer. So they looked at when they did bilateral ochiectomy or gave the patient estrogen, stilboestrol, and so that the marker they were following then, which was acid phosphatase, actually declined rapidly when patients were given these anti-androgen therapies. And this really established anti-androgen therapy as the main treatment for prostate cancer. Fast forward 40 years later, and we have now medical treatments such as leuprolide, which are your GnRH analogs, which actually showed non-inferior outcomes to DES and had a better side effect profile. So this really established androgen deprivation therapy in treatment of patients with metastatic prostate cancer. So if we look at systemic therapies for localized disease, so patients with localized disease will either have a radical prostatectomy, or they will have radiotherapy, and then they will also have addition of androgen deprivation therapy. And in localized disease, androgen deprivation therapy can be used in the neoadjuvant setting, and this is only in the patients who are going to receive radiotherapy. There is no strong evidence for use of ADT in patients who are going for radical prostatectomy. And obviously in the adjuvant setting, we use androgen deprivation therapy in localized disease, post-radiotherapy for 2 to 3 years. And also patients who've had a radical prostatectomy but have adverse features, such as having a positive margin, seminal vesicle invasion, extracapsular extension, detectable PSA after surgery, or if they were node positive. So there's clear evidence for use of androgen deprivation therapy. Mainly the drugs that are used are the LHRH agonists, and there are four main ones. And then we have the antagonist, which is the Garelix, and you can use them in combination with your first generation anti-androgens such as bicalutamide and flutamide. So moving on to patients with hormone-sensitive prostate cancer, probably this will be the largest group of patients that we will take care of in Africa, given the late diagnosis. So there's still a role for androgen deprivation therapy, but what's happened over the last 10 years is that we know that for some patients, ADT alone is not enough, and you can actually increase their progression-free survival and the overall survival if you add other treatments such as chemotherapy, using docetaxel, using abiraterone, enzalutamide, apalutamide, or also adding other first-line anti-androgen. So I think the discovery that docetaxel really helps in metastatic disease came from the metastatic castrate-resistant patients, but now has moved on to the metastatic hormone-sensitive patients. And there are three main trials that actually prove the benefit. We have the GET2 trial, we have the Chartered and the Stampede trials. And if you look at the highlights there, you can see that adding docetaxel to ADT actually improved the overall survival from between 13 months and 17 months, depending on the trial. So this was a very significant improvement in overall survival. And more importantly, the benefit was higher for patients who had more extensive disease. That is, patients who had more than 4 bone metastases and patients who had visceral metastases. So this is was an important advance in the treatment for metastatic hormone-sensitive prostate cancer. And then later came the use of abiraterone in addition to ADT, and slightly larger studies, and also showing that there was favoring abiraterone for improvement in radiological progression-free survival, which was quite significant. So the docetaxel came much earlier, and then in about 3 years ago, approval for abiraterone in the hormone-sensitive group. And thereafter, quickly followed with enzalutamide, which also showed a significant benefit in improvement in terms of recurrent radiological progression-free survival. And this was from last year, the use of apalutamide, also showing a similar benefit. So when we have such a high number of options to choose from, which were not there maybe 10 years ago, I think the most important question to ask is, how do you choose the patient? So you need to make decisions for individual patients, looking at this risk stratification, their physiological age, their performance status, whether they have other comorbidities. Remember that use of abiraterone requires use of prednisolone, and as well as when you use docetaxel. And then what are the expected toxicities for patients and the cost effectiveness of these treatments, which is very important for us locally. And you can see that there is a difference in mortality dependent on whether a patient had high volume disease or low volume disease, or if they had prior local therapy prior to getting metastatic disease. So these are the factors that we look. And Sweeney last year at the Advanced Prostate Cancer Consensus came up with this a possible way in which we can determine the type of treatment, and reserving chemotherapy for patients who have high volume disease and good performance status, and maybe using the oral treatments in patients who have low volume disease or who are not chemo fit. So moving on to metastatic castration-resistant prostate cancer, perhaps this is the kind of patient that will be with you for longest time and will have more challenges in the treatment. And what is advised is the continuation of testosterone suppression with ADT. And then there's a lot of evidence for including docetaxel, abiraterone, enzalutamide, which we use in the metastatic hormone-sensitive disease. But here we have immunotherapy, sipuleucel T. We have a second chemotherapy, cabazitaxel and mitoxantrone, as a third chemotherapy agents, but not forgetting that we have other secondary hormone therapies such as apalutamide, and other therapies such as steroids, ketoconazole, and DES. And just to show you how this has come about, of course, docetaxel was the first that was approved for this indication. And you can see over the last 16 years, there's been an increase in the number of drugs and different indications. And I will talk about the PARP inhibitors and the immunotherapies in my subsequent slide. So how do you choose what treatment for your metastatic hormone castration resistant patients? Then you look at whether they're symptomatic or asymptomatic, and you can either use sipuleucel T if they're symptomatic, and then moving to abiraterone. And basically, you're just switching from the treatment that you had not used before. And if the patient has exhausted all the treatments, then now we move to the current therapies, which are PARP inhibitors and immunotherapy. So what are these emerging therapies? So I just highlighted some of the trials that are ongoing. There's a new arm to the Stampede trial, which is looking at conventional medicine that we use for diabetes. So they're looking at addition of metformin, the use of transdermal estradiol. We've already talked about the Titan and the Aracent study. And then also they're looking at adding immunotherapy to gigarelix, so that is in the hormone sensitive group. And then if you look at what are these new emerging therapies, some are already in clinical use. There is immune checkpoint inhibitors, but they have been found to be only beneficial for patients who have a deficient MMR or MSI high tumors or other DNA mutant mechanisms. And the drugs that have been approved for some of these indications are pembrolizumab, and there's a trial looking at combination of nivolumab and ipilimumab. And if you look at the PARP inhibitors, these are approved for patients who have BRCA mutation and or who have homologous recombination deficient cancers in terms of them receiving benefit. And the three drugs that have olaparib has been approved, tucaparib and niraparib are in clinical trials. And then lastly, we have the PSMA targeted therapies, such as the radioligand therapy and the CAR T-cell therapy. And lutetium-177 is one of the drugs that is being trialed. Some of the other drugs that are being looked at are things like addition of valacyclovir, which is an antiviral drug, and combination of chemotherapy with nivolumab, which is immunotherapy, and dual immunotherapy with ipilimumab, nivolumab, and docetaxel. And also looking at using sipuleucel T for patients who have newly diagnosed prostate cancer. So there are lots and lots of trials that are coming up and new agents that are coming for prostate cancer. So I think I've kind of summarized. Thank you for your attention, and I'm happy to take questions.
Doutora Sitna Mwanzi, isso foi uma excelente apresentação. Devo, desde já, antes pedir desculpas por este ligeiro problema que tive com a comunicação, mas acho que já está pronto, resolvido e a plateia consegue ouvir-me, não? Isso. Mas foi uma apresentação esplêndida, acho que acabou trazendo para nós aquelas que são aquilo que existe de mais novo na abordagem do câncer de próstata. Acredito eu que, como sorologista e muitos outros colegas saberão disso, que a abordagem do câncer de próstata torna-se muito mais complexo quanto mais terapias exigir. Quando estamos naquela fase da monoterapia, ou radioterapia, ou cirurgia só, isto é uma coisa que torna-se fácil abordar. Mas quando chegamos a este ponto de fazer a mistura de hormônios, a quimioterapia, aí é que, na verdade, começa a ser uma grande dor de cabeça para nós. Então, está de parabéns, doutora Stina, e uma apresentação que aprendi muito, com certeza, aprendi muito. E não sei se alguém tem alguma pergunta para fazer, eu teria apenas uma. Não sei se alguém tem mais. Antes
Podemos
de
fazer
pergunta.
as perguntas no fim?
Sim? Alguém? Ninguém pergunta? Tá bom, tá bom. Então acho que vamos só uma questão, doutora Stina Mwanzi. Isso na vossa realidade, será que está sendo possível aplicar a hormonioterapia, neste caso, já com os níveis de bronzabiraterona, enzalutamida, no dia a dia tem sido possível usar estes fármacos? Porque na nossa realidade, em Angola principalmente, acabamos por ficar simplesmente por o Zoladex, a bicalutamida, a flutamida de vez em quando. Não sei se conseguem chegar a outros níveis. Sabemos nós que a biraterona, enzalutamida e estes de nova geração acabam tendo um maior bloqueio também periférico. Então, tem sido possível aplicar isto?
Yeah.
Fazer?
So thank you for your question, Dr. Apollinio. We are kind of privileged. I work in a private hospital, so we have access to abiraterone and enzalutamide, and docetaxel, of course, is an old chemotherapy agent. So, but because of the number of patients, we have also the brand product and we have the generic product. So the generic product is less expensive for patients. So for patients who can afford it, they can get it. And also we have a National Hospital Insurance Fund, which caters for some of the treatments for cancer. And these drugs are included. I think the challenge with drugs like abiraterone and enzalutamide is that you have to use them for a long period of time. Whereas docetaxel, you're giving your 6 to 9 sessions and you're done with it, and the benefits are almost similar. But also some patients obviously will not be are not fit enough to get chemotherapy and might be better off using the oral treatment. As yet, we don't have apalutamide and some of the second generation anti-androgens, we don't have them. We have access to immunotherapy, but it's extremely expensive, about $10,000 per month, so which is quite out of reach for most of the patients.
Tá bom. Obrigado, doutora Stina. Vamos então passar para a próxima apresentação. Vem o doutor Abubakar Belou, que é presidente da AORT, não é? Que vai nos apresentar então alguma abordagem sobre aqueles que são os guidelines para o tratamento do câncer da próstata. Doutor Abubakar, bem-vindo e exponha, por favor.
Thank you.
O tempo lhe pertence.
Okay, can I share my... Okay. So, hello.
Com certeza, com certeza.
Hello. Can you hear me? Can you hear me?
Yes. Yes, yes.
Yes.
Oh, sim, sim.
Okay. Thank you so much. I'm very happy to be here at the Palo IoTic Angola presentation. My name still is Bello Abubakar. I'm the president of IoTic. I'm also a chief consultant, clinical and radiation oncologist at the National Hospital here in Abuja, Nigeria. So I will be talking about resource stratified guidelines for prostate cancer. And my outline is why resource stratification, prostate cancer guidelines and prostate cancer guidelines for sub-Saharan Africa, and then I will conclude. I will try and answer all this in the next 15 minutes. Why resource stratification? Why do we have to have guidelines that have resource stratification? First, it guides you to have an evidence-based adaptation of available clinical treatment resources where certain diagnostics tests and other treatment approaches may not be available. In other words, the stratified guideline will give you the best evidence, yet you will be able to make certain diagnoses even if you don't have everything. And they are used widely around the world, including a number of low and even middle income countries. Because the goal of resource stratification is to define appropriate treatment pathways based on available resources and deliver a tool for healthcare providers to identify treatment options that will provide the best possible outcome given specific resource constraint. So we had a group called the African Cancer Coalition to produce the harmonized guideline for sub-Saharan Africa. And most of my talk will be guided around for the adaptation, or rather the harmonization of the guideline, the NCCN guideline for sub-Saharan Africa. So the guideline is aimed to reflect the heterogeneity of resources available across Africa. And what is the principle of adaptation? As a group, there are over 150 oncologists across Africa that came together to develop the harmonized guideline. And collectively, we aspire to and will continue to advocate for the highest standard of care for our patients, reflecting up-to-date science and the imperative to expand access to effective, affordable care settings where those standards are not yet attainable. In other words, what we try to do is to give the best of care for our patients at the time that even the best of care is not readily available. So what the NCCN harmonized guideline for Sub-Sahara is all about? They are targeted regional skyrocketing cancer rates and unique cancer circumstances. We do realize that about 22 countries in Africa have no radiotherapy machine, and they don't have even to treat patients. So they represent both the optimal care that low and mid-resource countries aspire to provide and pragmatic approaches that provide effective treatment options for resource-constrained settings. So there are 3 levels that we have identified. So we have color-coded them. We have the black, the gray, and the blue text. The black text are generally available standard of care, which refers to investigations and treatments that are usually available in cancer treatment centers across sub-Saharan Africa. The gray text are the highly advanced and they are optional, which refer to investigations and treatments that may only be available in advanced care settings. Those should be used if only they are available, but care should not be delayed or withheld even if they are not available. And then we have the blue text, which is an added option for the region, for Africa. We do realize that we do a lot of treatments that cannot have evidence yet, but they have some form of support to the patients, and we get some optimal results using them. And I'm going to allude to that later. So those are basic investigations or basic treatments that are prevalent in a lot of African countries where the high or the advanced settings or even the generally available standard of care are not available. So we do know also that the NCCN guideline is also stratified. This is the only guideline, in fact, that have resource stratification. And that is why we decided to adopt it, because we looked at all the resource stratifications. Sub-Saharan Africa. Of course, there are other prostate needs guidelines and so on and so forth. None of them has actually reflected and that is why we came together. Nice. So this is basically the prostate cancer guideline for Sub-Saharan Africa, which is domiciled on the nccn.org. And the prostate guideline was actually updated in August the 23rd in 2019. So what are the principles that we adopted for the prostate cancer care? We adopted that patients should be referred to centers that provide the highest level of care for a given clinical setting. Delays in treatment reduce the effectiveness of treatment, so efforts should be made to expedite investigations and referrals to reduce waiting time before treatment initiation. This is critical because we know that because of the delay, we tend to have a lot of advanced cases. In Nigeria, for example, about 86% of our cancers present at stage 3 and stage 4. So if we make concerted efforts to refer patients on time, that probably will also reduce. We also recognize that standards of care are based on reported achievable outcomes. So issues of cost, regulatory environment, and medical education and training are considerations that may affect treatment selection. Pathological review, biomarker use, accurate clinical staging, prognostic monograms, and multidisciplinary cares are recommended strongly. Improvement in 3 main areas of potential curative prostate cancer care are needed to reduce variabilities among and within countries. For external radiotherapy, capacity needs to be increased in IMRT and IGRT. For brachytherapy, high dose and seat availability must also be increased. And for radical prostatectomy, surgical skills and experiences must be improved, especially to allow salvage and minimally invasive radical prostatectomy. So these are the principles that guided what we are doing. And people are encouraged not only to go directly into the guidelines, but also see the principles on which they are formed. So I have mentioned this. This is what is on text is generally the available standard of care. The gray is the highly advanced, while the blue is the regional options that we may consider when every other standard of care is. Survival of over 20 years and above. The initial include active surveillance, which is consider multiplanar MRI and or prostate biopsy to confirm candidacy for active surveillance. We do know that in most of African countries, we may have MRI, but we grade consider multiplanar MRI and prostate biopsy. Of course, PSA is very much available in most of African countries. DRE is also very much available, and people can actually repeat prostate biopsies as well. And that remains as black text. But we also included something here very critical, which is this is the yardstick that most people use because it's not always available to have a prostate biopsy. But when you recognize that the doubling time, the PSA doubling time is shortened, then you start to think that the patient needs further treatment beyond just surveillance. So anywhere you see repeat multiplanar MRI, it is great. What that means is it's not readily available, but it is still there in the guideline, and it means people are encouraged to be able to do multiplanar MRI. It is our hope that with development in sub-Saharan Africa in terms of cancer care, we will be able to turn all the gray text into black text and totally remove the blue text. That, of course, we know will take time, and it is something that we hope to get as quickly as possible. Look at the high or the very high risk groups, which is stratified as over 5 years, you know, the expected survivor. External beam radiotherapy and ADT is readily available in most of sub-Saharan Africa. External beam radiotherapy and brachytherapy and ADT is also prevalent, even though high dose rate may not be too prevalent, but at least external beam radiation therapy is very much available in most of sub-Saharan Africa. And that is why we decided to leave this whole thing gray, black, sorry. The same thing goes for when you are looking at the PSA persistent or recurrence. You see that one of the things that you need to do in terms of imaging is CT scan, bone scans, and PET CTs. But PET CT is not readily available in sub-Saharan Africa, except in, of course, South Africa and now in Kenya. I'm happy to note that. But you can perform axial bone survey. That is an X-ray if bone scan is not readily available. Now, this is not in the parent guideline because in the United States, nobody does axial bone survey because they have readily available bone scans. So we included it as blue, which means it's purely for sub-Saharan Africa. By the time we hope that we get available bone scans across the region, that blue will definitely come out. So we also looked at chest CT, which is also readily available in most parts. But if you are in a rural area where you don't have access to chest CT to make a diagnosis of recurrence or a metastasis for that matter, you can do a chest X-ray. Chest X-ray is not on the parent guideline of the NCCN. So we investigations that you can actually do. We intentionally left untouched most of the principles of image treatments, including radiation therapy, ADT, and so on and so forth. This is to allow the clinicians to look at the standard of care. How do you perform it? Because the principles, for example, of imaging will take you step by step what are the investigations that you will really need to make a diagnosis of prostate cancer and to do follow-up as far as imaging is concerned. So you can see that it talks about the goals of the imaging, efficacy of the imaging, the plain radiography, ultrasounds, bone imaging, where you talk of SPECT, bone scans. So we included there axial bone survey in case you cannot do a bone scan. That is the only correction that we imputed there. Again, we look at certain things that are not readily available. Multiplanar magnetic resonance imaging, MRI, is not readily available. So we grade it, not because generally magnetic resonance imaging is not available, but it will guide the clinician on the need to do the right thing, to do the multiplanar MRI, which is not just like any other MRI. So if you don't know how to do it, then you come to the principles of imaging and you can learn from that. The same thing goes for the PET CT, PET MRI, and so on and so forth. You can see that we have totally graded most of the nuclear medicine imaging protocols. This is because nuclear medicine has not really developed in a lot of sub-Saharan Africa, even though you can see nuclear medicine evolving in so many African countries. So it is hope that in the not distant future, this gray page will be black so that everybody will be able to use PET CT, PET MRI, and so on and so forth. What of the principles of treatment, radiation therapy? We do know that external beam radiation therapy is relatively available. We have many countries with cobalt machines, with linear accelerators, even though, like I mentioned earlier, 22 countries in sub-Saharan Africa have no single radiation machine. So you are able to do basic things. But proton external beam therapy is not available yet in sub-Saharan Africa. And because of that, we have also graded that area. And so that you should use conventional external beam radiotherapy at doses described in institutional protocol, where highly conformal radiotherapy techniques are not available. This is because we do 2D treatment, and when you do 2D treatment, it's not likely that you are able to spare a lot of the organs at risk. So you will not want to do dose escalation and take, say, the dose to 72 gray. So because of that, you have to use the institutional protocol. This is not in the current guideline, but we felt it is important that clinicians must recognize that they don't need to take the dose to the maximum acceptable because of the risk to the other organs. The same thing goes for radionuclide treatments. Actinium-123 and so on and so forth, they are not readily available at
Parece que houve algum problema
Bem,
com
acho que acabamos
a
perdendo
apresentação.
o sinal
Pois
do
é.
Abubacar.
Eu estou aqui a tentar ver se ele aparece.
Para ver se ele volta. Para irmos para as últimas considerações.
Ele estava com algumas dificuldades, nós fomos percebendo ao longo da apresentação. Entretanto, ainda não voltou a entrar.
Mas daquilo que já foi dito, não sei, Dr. Júlio Santos, quem aí será alguma consideração?
Não, do que foi dito pelo Dr. Abubacar, que está sendo uma apresentação maravilhosa, mas infelizmente tivemos deficiências técnicas. É para dizer que realmente nos países africanos, sobretudo na África subsaariana, temos alguma dificuldade em recursos, temos que traçar algumas guidelines de acordo às nossas condições que temos, e de princípio para dizer que em Angola, felizmente, temos algumas soluções. Não é para todos, mas temos a medicina nuclear, podemos fazer a cintigrafia óssea, podemos fazer a ressonância magnética. Então, uma vantagem que temos para fazer um bom estadiamento dos nossos doentes e oferecer uma melhor terapêutica. Nesse caso, nos hospitais públicos, nós temos colaboração com as clínicas, sobretudo com a Gerassol, onde temos a medicina nuclear, e os doentes têm se beneficiado de uma forma direta. Também, em termos dos nossos doentes oncológicos, nós trabalhamos de uma forma multidisciplinar com o Hospital Oncológico, o IACC, então conseguimos enviar nossos doentes e são bem tratados, porque isso tudo tem a base do princípio, é uma consulta multidisciplinar. Por exemplo, eu trabalho na Meco Boa Vida, temos algumas limitações de algumas especialidades, sobretudo foro oncológico, mas temos, falando com os colegas da oncologia, e conseguimos os acertos, os doentes têm um tratamento adequado de acordo à nossa realidade. Passo a palavra para o doutor Apolinho, não sei se quer dizer mais alguma coisa.
Exatamente. Não sei se dos outros participantes têm alguma consideração a fazer mais. Talvez aproveitando esse tempo que ainda temos, né? Já que acabamos por perdendo a nossa apresentação, mas algo que a doutora Astina nos apresentava, principalmente quando falava sobre o estudo Charted, não sei se a doutora Astina ainda está por aí, o estudo Charted,
Yes,
não
I'm
é?
here.
Não sei se ela aí se referia exatamente à doença metastática de baixo volume e de alto volume, a classificação. Doutora Astina? Acho que não está presente, não?
Thank you for the question. I think that when they did the trial, they decided to divide the patients into patients with low volume disease or high volume disease. And the high volume disease is classified as patients who have visceral metastases, that is metastases in the liver or the lung, and or patients who had multiple bone lesions. And they said if a patient had more than 4 bone lesions, and one of those lesions was was outside the vertebral body, then this was a high volume disease. So when they did the study, they found that the patients who had high volume disease benefited more from chemotherapy as opposed to those who did not get chemotherapy. But so this is basically one of the risk stratifications that we can use to decide which patients get what treatment. You know, we have patients who have metastatic disease, but when you do imaging, you don't find anything, and those are the ones we call biochemical relapse. And for those patients, androgen deprivation therapy alone could be beneficial. But more commonly, at least in our setting in Kenya, we have patients who have a lot of extensive disease, whether it's in the bone or nodal disease. And those patients with high volume disease actually do better if we either give them chemotherapy using docetaxel or added abiraterone to their androgen deprivation therapy. So I think we need to look at this keenly because the benefit is more than a year improvement in overall survival. So 13 to 17 months improvement, which is a huge improvement in outcome. Docetaxel is quite commonly available because we use it for other malignancies. And when you do 6 to 9 cycles, then you get the same benefit. So this is something that we in Africa, for our patients who are chemo fit with a high volume of disease, would benefit. I hope that answers your question.
Não, com certeza. Foi satisfatória a resposta. Nós temos aqui algumas questões. Exemplo, a um dos participantes que pergunta sobre o doutor Carlos Lopes pergunta se preconiza o rastreio do câncer da próstata pelo PSA sérico, se sim, em que faixas etárias? Eu acho que o doutor Abubakar voltou. Estamos de volta, doutor.
Yes, I'm so sorry.
Podemos então concluir a
so sorry, my
apresentação?
internet just went off. We have a lot of difficulty today because it's a festival and everybody is online in Nigeria, so I'm so sorry. I don't know if I can. I will quickly conclude it, if it's okay.
Sim, acho que sim. Podemos, sim. Uma conclusão para todos.
Okay, thank you. So I was just on this slide, I was talking about the androgen deprivation therapy that Sitna alluded to. You can see that there are certain drugs that are not readily available. Enzalutamide is one of them, apalutamide is another, and the combination of abiraterone are in Africa. I don't know of any center that use actually methylprednisolone. So because of that, that is also great, as you can see. And so enzalutamide and apalutamide across sub-Saharan Africa. That will make the gray area also black. So in conclusion, resource stratification enable you to use what is available to give basic evidence-based cancer care to the patient. If basic resources for cancer treatment are unavailable, palliative and best supportive care should be provided. The NCCN harmonized guideline are the biggest work collectively done by African clinicians that work and understand the clinical settings in sub-Saharan Africa. So I urge you to embrace it, use it, criticize it, but you must use a guideline. Thank you for listening and Eid Mubarak. Thank you.
Obrigado, doutor Abubakar. Muito obrigado mesmo. É bem, como é bem verdade que já estamos quase acima do tempo também, né? Neste momento já 15h56, já estamos acima do tempo, ou ainda temos algum tempo acrescido, por acaso? Sim. Tá bom, então, doutor Abubakar, é bem verdade que pronto, a questão da abordagem do câncer de próstata em África não é só uma questão, quer dizer, não é uma questão de conhecimento ou de falta de conhecimento por parte dos médicos, sobretudo da África subsaariana, né? Está muito bem claro que é por questões financeiras, condições materiais, né? O acesso a tecnologia. Este acaba sendo o nosso limite e com consequente repercussão sobre a qualidade do tratamento que então faríamos ou que poderíamos prestar para os nossos pacientes. Ao ver um guideline como este, que se adequa à realidade da África, só nos facilita, né? Só faz com que prestemos a melhor assistência possível dentro dos nossos moldes. Então, apresentação brilhante, obrigado por isto. Acho que todos os outros estão também satisfeitos com a apresentação. Temos aqui algumas perguntas, né? Não sei se ainda vamos a tempo de vermos a questão, algumas perguntas.
Thank you.
Pronto, alguma pergunta do Dr. Carlos
Thank you.
Lopes, que falava sobre o uso do PCA, não é? O PCA sérico para o rastreio. E em que faixas etárias? Isso, não sei se bem que não se enquadra muito bem num desses temas, mas não sei se alguém quer dar alguma consideração, Dr. Júlio?
Sim, doutora Pauline. Em primeiro lugar, queremos aproveitar, temos pouco tempo, mas vamos ver se vamos dinamizar um pouco. Queremos agradecer aos palestrantes, que fizeram uma apresentação brilhante, agradecer os PALOP pela organização. Realmente a organização tem sido brilhante, apesar de alguma dificuldade técnica pela internet, mas isso é resultante próprio da situação. Para a doutora Mwanzi, quero fazer uma pergunta. Qual é a sua experiência com relação... Sabemos que em África há muita dificuldade com relação ao Zoladex pelo seu custo. Muitas das vezes, nós os cirurgiões avançamos por a castração cirúrgica. Eu não sei qual é a experiência que tem com relação a isso. É a minha pergunta.
So, thank you, Dr. Carlos, for the question. So, we have a mixed picture. There's some men who do not favor having surgery and would prefer having the injections. But if you think about it, the surgery is actually a cost-effective way of doing things because it's a one-off surgery, and then the injections are, at least in our part, still quite significant cost, about $200 per injections every 3 months, which could be out of reach for many patients. So we find patients in the more rural areas favor surgery, and we have other patients who are just not keen to have the surgery done. So it really goes down to how the surgery is explained to the patient, that it has the same effect with the medication, and whether there are cost factors to be accounted for. So there's a variable uptick in terms of surgery.
Também muito obrigado pela consideração. Também gostaria de fazer uma pergunta com relação ao estadiamento. Se no Quênia tem todos os exames para o estadiamento, ou tem alguma dificuldade, como nós às vezes também não apresentamos.
Yeah, there's the reason I didn't present Kenyan data is because there wasn't anything for me to present. I think some of the challenges, as you know, is that prostate cancer patients are shared patients. They can either be seen by urology and oncology. So record keeping can be challenging for these patients. But I would say from my clinical practice that majority of patients have advanced disease. Very rarely do we get patients with localized disease.
Também muito obrigado pelas respostas. Vamos ganhar tempo. O doutor Abubacar, infelizmente, não está para aparecer. Passo a palavra ao doutor Plínio Paz para fechar a sessão. Não sei se tem mais alguma coisa a considerar.
Eu acho que não. Então, de parabéns a todos. Obrigado pela vossa apresentação e quem nos pronto, acompanhou. Tá? Então, esperemos que pronto, consigamos ter reuniões mais frequentes deste gênero. Então, vamos encerrar por aqui a nossa sessão. Tá? Então, paz e bem para todos.
Thank you.
Obrigado.
Thank you.
Obrigado.